Hello, welcome to the 2021 Conference of the Illinois Association of Free and Charitable Clinics. The Illinois Association of Free and Charitable Clinics, or the IAFCC, strengthens and grows Illinois free and charitable clinics without whom over 100,000 uninsured and underinsured patients would otherwise have no access to quality health care. The IAFCC helps free and charitable clinics move effectively into the future, advocates for the uninsured, supports clinics' volunteer workforce, and connects clinics to resources. This year's conference theme is New Decade, New Challenges, New Solutions. We are so grateful to all of our conference sponsors. Hello, my name is Patricia Wolf, and I have a PhD in nutrition, and I'm also a registered dietitian. I'm currently a postdoctoral fellow at the University of Illinois, Chicago, and I'm also a clinic dietitian for Champaign County Christian Health Center. My topic today is about medical nutrition therapy in the free clinic, using nutrition education to mitigate health disparities. So Champaign County Christian Health Center is a nonprofit health center ran almost solely by volunteers. The clinic offers free health care for the uninsured and underinsured. So how did I get involved with Champaign County Christian Health Center? Well, I truly believe that this clinic fosters the next generation of healthcare workers. I started as a hospitality volunteer in 2008 when I basically just greeted patients. And then in 2009, I transitioned to triage after I got my EMT certification. And so this let me have the ability to start taking blood pressures and get used to speaking with patients about healthcare information. I was a made triage team lead and began scheduling and training new triage volunteers. And then in 2014, I took a break from volunteering so that I could earn my PhD in nutritional sciences. And then just randomly, I decided to also become a dietitian while getting my PhD. And then in 2019, I returned back to the clinic with the new role of clinic dietitian. So why did I decide to focus on nutrition? Well, it is estimated that 1 in 5 deaths can be attributed to diet. So here you can see this was from a study done which looked at dietary risks in 195 countries, and it was published in The Lancet. And it showed that globally, about 22% of deaths were diet related. And when looking at higher income North America, which would include the United States and Canada, about 18% of deaths were related to nutrition factors. And so this included low fruit, low vegetables, and low whole grains, but especially like in America, some of these dietary related deaths are related to high processed meat intake and high sugar sweetened beverage intake and high sodium intake. And unfortunately, the burden of diet related death is not equitably distributed. So here you can see on the right different types of diet related deaths. And if you focus mostly on the bright dark orange bars and the dark blue bars, dark orange being the combination of high and middle sociodemographic index, and the dark blue being low and middle sociodemographic index, you can see for most of these dietary factors that this actually affects those with lower sociodemographic index. And in the US, this is particularly concerning since those with lower sociodemographic indices are likely to be racial and ethnic minorities. And so they often live in neighborhoods of extreme poverty. In front of you is a table that shows residents from the 1980s and 2010 and their likelihood of living in either high poverty or extreme poverty. And if we look at just 2010, you can see that, especially for African American Blacks, they have almost looks like a 5 times higher risk of being in neighborhoods of high poverty. This is also quite poor for Hispanic or Latinx populations. And so you can see that these populations are quite affected. And given that we see that people with lower socioeconomic index have diet-related diseases, and that racial and ethnic minorities live in high poverty neighborhoods, it's not surprising that this is actually affects life expectancy for many of these populations. So on the left, you can see this is people living with below or above the federal poverty line, and with below being the bars in white. And when looking particularly at African American Blacks, you see that they have quite low life expectancies that are related to income. And on the right, when we look at people, the percentage of people who have diabetes, you can see that those living below the federal poverty line in white again have a much higher risk of having diabetes, particularly those that are African American, Black, or Mexican American. And so just to give you a example from my own research, we published a few papers looking at colorectal cancer disparities in African Americans. So most of my research thus far has looked at colorectal cancer. And the reason that we have focused on this is that colorectal cancer is actually the 3rd leading cause of cancer death in the United States. And the importance of studying colorectal cancer is highlighted when you look at incidence and mortality rates stratified by race. So non-Hispanic Blacks in the United States have the highest rate of colorectal cancer. And this is as a group, but if we look at Alaskan Natives separately, they actually have the highest risk, but this tends to be washed out when they're put together with American Indians. And this is even worse when looking at death rates. So non-Hispanic Blacks, once again, have the highest rate of colorectal cancer death, and this is about 50% higher that of non-Hispanic whites. And so one might think that given that there's differences in race with colorectal cancer, that this might be attributed to genetic factors, but in general, the majority of cancers of the colon are sporadic. And so it's pretty well accepted actually that it is likely environmental triggers that actually spark the change from a normal epithelium to adenocarcinoma. And it's pretty well established that both diet and the gut microbiome are risk factors for colorectal cancer. So when we, so on the left, you can see a chart that shows the increase in risk compared to red meat intake. And so as grams of red or processed meat increase, the estimated risk of colorectal cancer also increases. And on the right, this is just showing general total microbiome differences between people who who are controls, who only have one, have a polyp, or have colorectal cancer. And you can see that their gut microbiomes separate from each other. And so we believe, or we hypothesize, that the microbiota may differ in colorectal cancer patients compared with controls due to intake of a Western diet. And the thought here is that with intake of a Western diet, it actually provides certain types of proteins to gut bacteria that are able to metabolize these proteins to produce a genotoxin called hydrogen sulfide. And this hydrogen sulfide then interacts with the colonic epithelium, leading to that trigger of cancer. And not to get too deep into it, but we looked at bacteria that produce hydrogen sulfide, and these are all different types of bacteria. And we saw that basically that in most of the markers we looked at, that these bacteria that produce hydrogen sulfide were 10 times higher regardless of disease status. And then we decided to look at differences between African Americans who had colorectal cancer and those that were controls. And we saw that in early onset cancer, or for those under the age of 50, that bacteria that were known to produce hydrogen sulfide were associated with cancer. And we thought this was interesting because studies have shown that African Americans are more likely to have early onset colorectal cancer, and this is usually associated with poor long-term survival. And then interestingly, when we looked at some of these bacteria that produce hydrogen sulfide, we saw that they positively correlated with markers that are associated with a Western diet, that being cysteine, which is a type of protein, fat, and African American race. And so we concluded that African Americans did have a higher abundance of these bacteria that produce this genotoxin, and that this might be associated with diet, but we're now doing follow-up studies to try to further tease this out. And so you might be asking yourself, what does this have to do with our clinic? And it may seem a little separate from what we're doing, but in fact, a healthy lifestyle may prevent 47% of these colorectal cancers. And so there's research that shows that changing from a diet high in red and processed meats to a diet that's high in fiber and high in calcium, and then also increasing exercise can prevent a lot of these cancers. And also reducing excess body fat could reduce the risk of 11 types of cancer and prevent over 132,800 cancers annually, which I found to be pretty shocking. So it's evident that even though many of our clinics don't work with patients who have cancer per se, that a lot of these people may be more likely to be affected by cancer and have, and that we may be able to prevent that with lower cost measures like dietary interventions. And on top, this isn't just about cancer. Some of the diet related diseases that were observed in this this previous study that I first mentioned, it showed that both cardiovascular disease and type 2 diabetes were also quite abundant causes of death attributed to diet. And so one might be like, great, we're just going to tell people to eat better, and then we're going to prevent all of these diseases. But social and economic factors often drive a lot of dietary choices in our patients. And so before you are various, what people like to call social determinants of health. And while many of the clinics that are listening right now are helping with this last one, the healthcare system and lack of healthcare coverage or poor quality of care being something that may drive health outcomes, there are other factors that many of our patients face, and that would include economic stability, neighborhood and physical environment, education, food, community, and social context. And food actually doesn't just touch this one section. It's not just about access to food, but a lot of these other social determinants drive food choices. So economic stability may drive choices based on it, whether you have the money to purchase food, but it may also drive what you purchase based on how expensive it is. Neighborhood and physical environment, there is pretty consistent evidence that neighborhoods of lower socioeconomic status have less access to full service supermarkets. And so this means that a lot of people in those neighborhoods may not even have access to the type of healthy foods that we're trying to ask them to eat. People may live in neighborhoods where the education didn't have the ability to focus on health education or food education. And in terms of community and social context, besides the fact that people may not have that, nutrition may be kind of the lowest priority compared to so many other stresses that people are dealing with in these neighborhoods, but also that we have to be aware that there are different, that what constitutes a healthy diet or a healthy body composition may not be the same between different communities. So what can we do as a clinic to help our patients eat a better diet and maybe help mitigate some of these disparities? So first, looking from a policy level, is something I'd never thought about being involved in, but it turns out that many societies or associations that we may be involved with as clinicians or scientists actually have advocacy efforts in place to bring our opinions to policymakers in order to create change for our patients. So, for example, the Society of Behavioral Medicine releases policy briefs and position statements, and they also have a advocacy network in place in which they bring these briefs to policymakers in order to bring them to their attention. And so a policy brief basically is a pretty short 1 to 2 page paper which describes a major healthcare or public health problem, what current policies are in place, and then policy recommendations that can be made to improve the state of that public health problem. And so just briefly, I looked and I saw that also the American Medical Association issues briefs such as these in order to advocate for patients. And so if I can do it, you can do it too. I'm decided to try to utilize some of these advocacy streams, and I, along with colleagues, wrote a position statement about supporting policies that foster a healthy food environment and incentivize healthy food purchase to mitigate cancer disparities. And basically what this paper is advocating for is for policymakers to approve policies that, like ones that increase the purchasing power of nutrition assistance dollars. So, for example, WIC, making WIC dollars worth more on the dollar towards the purchase of fruits and vegetables. And research has shown that these types of incentive programs can actually do a lot towards not only increasing fruit and vegetable intake in affected populations, but can also mitigate health disparities. And so we're hoping to submit this to translational behavioral medicine soon. You can also talk about nutrition at the clinic level. So our clinic coordinator, Crystal Ho, had the idea to have a nutrition education event for our patients. And so she got multiple parties involved in having several different booths in which patients could go to and learn more about nutrition and health. And so, for example, here, I had a dietetics student work with me. Well, basically, she did most of it, where this is a Jeopardy board, and patients could come up and try to answer questions related to nutrition and health. And in return, they either received a small prize or they were eligible for a big prize. And the big prize being a basket of either fruits or vegetables. And these fruits and vegetables were donated in coordination with 2 local farms and the local food co-op. And one of the farms in particular was really excited to donate because they were also a faith-based organization that whose goal was to increase nutrition access to communities who have less access. And on the right here, this is actually one of the people involved in coordinating this event got in touch with, I think this is SNAP Ed, or it might be FNEP, but basically the Illinois Extension has these nutrition programs in place that are involved at the national level. And their whole goal is to improve nutrition in people who utilize SNAP benefits. And so the person who came from that group actually made a chili that she gave out samples to, and then she had had the recipe along with her, and it was made out of pretty low cost ingredients. And so patients were able to sample a low cost recipe that was high in fiber and pretty good for you. So that was the whole event was actually just really successful. You can also communicate nutrition at the provider level. So first of all, I would say the most important thing is to meet patients where they are. No food is bad. It's just a matter of portion. And basically what I mean by that is so often when you try to speak about nutrition with people, they just think that everything they're doing is bad. And so it's too difficult to make changes, or that the changes need to be completely different than what they're currently eating. And often people will fail when they're trying to do that because it's just too big of a hurdle to climb. And so instead we talk about, what are the foods you currently eat and how can you keep eating foods that you like, but just not eating so much of them. Also, we talk about that it's not about weight, and it's more about health. It's important for many reasons not to focus so much on weight unless that's a goal of the patient. So, I mean, first of all, you don't know the mental health background of the patient in regard to food, and then all different cultures may think a certain body composition is more healthy, that in a way that's different than what we tend to objectify in the United States. And so I think it's important not to tell someone that their body composition is wrong, but it's more about trying to achieve, measurable benchmarks that can be measured by their doctor, that will help them feel better and be more healthy in the long run. I also think it's important to ask what patients eat to eliminate any assumptions, because sometimes patients are already doing a pretty good job, and it's actually a different lifestyle factor or a genetic background that's leading to some of these nutrition related laboratory markers. So I think that's important. Also, if you ask people what they eat, then you have a better idea of what small and attainable goals that they can set so that they have successes and want to continue on this lifestyle change. And then also, it's important to understand that not everyone eats a standard American diet. Our patient population is fairly diverse, and if I don't ask what they commonly eat, and I start right away with nutrition education material that has sandwiches on them or pizza or other American fare, they may already not eat those things, and so we're kind of fighting a losing battle. Or speaking a different language. And then I think it's really important to advocate for diets supported by research. So for diabetes, that would be a consistent carbohydrate diet. For hypertension, that's the DASH diet. And for basic health, that would be MyPlate. And so there's a lot of free online resources for education material to give to patients, especially for MyPlate. The American Diabetes Association has pretty good guide that is free and available for diabetes. And then there's many free guides out there for the DASH diet. And if all else fails, MyPlate is a super easy place to start. And this might sound silly because, you look at this graphic and you're like, okay, who cared about the food pyramid? Who cares about MyPlate? But usually if I ask patients what they're eating, and we talk about the first measurable change just being filling half your plate with fruits and vegetables, many people find that to be something that they can obtain. And I'll give you an example. So if you look on the left over here, this, and you grew up in my household, this is basically what a dinner would look like. It's pretty much the whole plate is full of spaghetti, and we would eat this several nights a week. And part of that was due to financial constraints for my family, but also just due to the norms of how my parents grew up. And and not having other information available. And so on the right, this is a little extreme, but this is a meal that I made for my family. And you can see over half the plate is filled with vegetables. And it looks fancy just because I put some spices on it, but it's mostly just lettuce and chopped tomatoes. And then half the plate is spaghetti. So you have your carbs and your protein in the meat sauce. And when talking to patients, you know, asking them to go out and buy a bunch of raw vegetables can be a huge ask, especially if it's not available in their neighborhood. But if available, many patients tend to agree that they can buy bagged salad mix and just throw it on their plate, and, in order to get a little bit more fiber. Another really easy thing I talk about with my patients is utilizing frozen vegetables. I love frozen vegetables because they take about a minute to cook. So if you have a microwave, you can just heat it up in there. If you don't have a microwave, you can heat it up on the stove in some hot water. And then you just instantly have, half your meal complete. Usually frozen vegetables don't have added sodium, which is great for our patients with hypertension. And also, because they're frozen, they tend not to spoil, which is an important factor when we're talking about food prices and fitting vegetables into our diet. So also a lot of power with the food label. So I really try to talk about not getting overwhelmed by the food label and counting when we're talking about diets with patients. So for example, if I educate patients on the food label, I mostly tell them to look at either one or two things on the label in order to empower them to make better purchasing decisions. So if we're talking about our subjects, or not subjects, our patients who have diabetes, we often want them to have a consistent carbohydrate diet. And so that would look like having 2 to 4 servings of carbs at meals and 15 or 1 serving of carbs at snacks, and usually a serving being about 15 grams. And so if we look at this food label, this under total carbohydrate, this, whatever this item is, would have about a little over 2 servings of carbs. And so if this were a meal type food, then 2 servings of carbs would be, an appropriate choice. But if this is just a snack, this might not be an appropriate choice because it's over twice as many carbs as one should aim for during a snack. And so that allows the person to either decide to pick something that has fewer carbs or to lower the serving size to smaller portions so they can still have the thing that they want as a snack. Similarly, looking at sodium, I try not to tell people that they need to count their sodium all day, or, but that they should think of this as like a portion of their daily allotment. So if they're deciding to purchase between purchasing this item and another item, if this were a can of soup and it was 160 grams, that's most of your meal that you're eating. Maybe you have a sandwich. And so maybe this might not be too bad because it's 1/10 of their daily allotment of sodium. But if this were just a snack and it were, a couple of crackers or something, then maybe they'd want to look for something that was lower in sodium so that they can, still enjoy their food without it being so harmful for their health. So I've seen a lot of really great changes in some of my patients who taken the advice to heart and made small changes. Actually, one person completely needed to come off of their blood pressure medicine because they did such a great job with lowering their sodium intake. But I still see places where we can grow. And one of those places is I'd like to see culturally competent nutrition education material. And so what does that mean? That just means having education material that has foods that people recognize based on where they come from. So on the left here, or just to give you some background, we have a pretty large population of French Congolese patients that come through our clinic. And a main staple of their diet is fufu. And fufu is a starch-based food that is made from a variety of different vegetables depending on what region you're from. And it's pretty high in carbohydrates. And if I started if I had a patient with diabetes, I started the conversation without ever talking about this staple food in their diet, then I may be missing something really important that's affecting their blood sugar. Similarly, on the right, we also see a lot of patients from Vietnam, and it's important to have some knowledge about some of the sauces and spices utilized in the foods in order to talk about controlling hypertension. And so I'd like to see more material that has these foods so that we can start off on the same page. I'd also like to see more nutrition education material available in multiple languages. So MyPlate does a pretty good job at this. They have a lot of their information sheets available in different languages, but I haven't looked recently, but I have a really hard time finding anything in French. And I find this pretty surprising. I'm not sure why, but what's difficult is if I'm speaking to a patient with an interpreter and I'm giving them nutrition education material that it's completely in a different language than what they usually read, then it's just not really helpful material, especially something that like this, which is almost completely words. And so I've been trying to mitigate some of these problems by getting dietetics students involved, and we've started trying to make some sheets that have culturally relevant foods. But I now that I've been doing this for a while, I believe a better way, and maybe a way that would work for a greater number of people, would be for organizations like this to partner with people who come from these cultures to make relevant material for our patients. So with that, I'd like to thank you. I hope you learned something from my talk. First of all, I'd like to thank thank you for having me speak. And I'd like to thank the amazing people at CCCHC. Crystal Hogue, especially our clinic coordinator, asked me to speak at this conference. And Dr. Jeffrey Trask is the founder of CCCHC. I'd also like to thank the board that keeps the clinic running, and the nurses who've been working for years at this clinic. So Warner, Carmen Zeich, and Ann Berger, who actually wrote recommendations for me so that I could go to graduate school. So without them, I may not be here. I'd also like to thank my students, Luke Lucio, who actually did research with me in at the U of I, and then he has a passion for the French language, and so he actually started volunteering in triage at CCCHC and also served as an interpreter. And he's in France right now, teaching to French students. So, and then there's also Judith Wen, who prepared that amazing board for the nutrition education event that taught so many people about health education in a fun way. And then also my mentors with whom I did research and my sources of funding that funded the research that I presented today. All right, thank you very much.